Perfect. So welcome everyone. My name is Dr. Simon Erridge. I'm the head of research at Sapphire Medical Clinics and also a clinical research fellow based at Imperial College London. And welcome to you all to our evening or morning or afternoon webinar, I guess, depending on where you're joining us today, which is really focused on chronic pain. And we have a number of different representatives who are experts in their own respective fields with respect to chronic pain, and we're going to be having some really interesting discussions around chronic pain and also how the sort of evidence and guidelines are evolving with respect to chronic pain in and of itself, but also given our focus as a medical cannabis clinic as well, how medical cannabis plays a role in that as well. So just to introduce you to our panel today, we have the Fibromyalgia Action UK Chair and a chronic pain patient, Mr. Des Quinn. We also have the Associate Director from the Michael G. de Groot Centre for Medical Cannabis Research, Dr. Jason Boos, chronic pain consultant and medical advisor at Arthritis Action, Dr. Wendy Holden, and finally, but by no means least, advanced specialist pharmacist here at Sapphire Medical Clinics, Katie McLaughlin. Just before we start, just a general reminder that everything we discuss here is just for educational purposes only and should not be taken as medical advice. And we would always recommend that you seek help from your general practitioner if you have any queries. But really, just to get started, Des, I would like to come to you first, if that's okay, and maybe if you can give us some perspective of your lived experience with chronic pain in the UK.
Thanks, Simon. So I'm Des Quinn. I'm chair of Fibromyalgia Action UK. I've been involved with the charity for it's close on 2 decades. I'm very much a volunteer still with the charity. I'm a patient advocate, but I'm not a medical professional. But in my time, I literally was diagnosed with fibromyalgia one day and became involved with the charity the very next day. I was lucky in the fact that somebody I knew was already within the charity. Now that gave me the opportunity to find out quite a lot about fibromyalgia very quickly, beyond my own personal experience of chronic pain up until that point of being diagnosed. Because as with most people with fibromyalgia, it takes a significant amount of time that you're existing with chronic pain before you perhaps find what's causing it and then start to think about how you will potentially live with it and move on with it. And in those sort of 2 decades, I've been quite fortunate in my levels of chronic pain are such that I am able to continue to work. I am able to volunteer for the charity, but there's so many within our community that are suffering with chronic pain to the extent that they're in a wheelchair or they are bedbound. But it's not just chronic pain. There's more to fibromyalgia than that. But since we're talking about chronic pain in this particular webinar, it's always the way that fibromyalgia is sort of described as, first of all. And it's constant. It moves around. If you're taking a medication for it, which I am lucky that I benefit from taking tramadol, one of the opioids that perhaps are frowned upon, but it helps me greatly. It allows me to get my day started. It allows me to work. It allows me to live. And not everybody's so fortunate. And that chronic pain can come and go. It can move around. And one of the things that a lot of health professionals perhaps don't appreciate too well is the fact that when a medication brings you down from, let's say, 8 to a 4, on this imaginary 1 to 10 pain scale, you're still living with a pain of 4. You're still existing constantly with that pain. You're never pain free, and any activity, any movement can potentially give you that little acute amount of pain that just makes you remember, yeah, it's here, it's with you. So that's why webinars such as this, educational, to discuss how chronic pain is dealt with, how perhaps cannabis can play a role, how other medications perhaps interact as well, is quite interesting and very glad to take part. Is that okay, Simon?
Oh, of course it is. Thanks, Des. And maybe if it's okay, would you mind sort of describing what aspects of healthcare do you come into contact with as a chronic pain patient? You know, I presume you see your GP, but do you see hospital specialists, pharmacists, physiotherapists, etc.? You know, who's involved in your care pathway?
Well, to be honest, I'm a typical man and trying to stay away from the doctor as much as possible. And for the most part, the tramadol that I take does keep me on an even keel. But every once in a while, I'll go and see the GP. Initially, I saw the GP, then the rheumatologist, and got a diagnosis there, pretty much to exclude other conditions. And after the blood tests and whatnot were done, but every now and again, I'll go and see the GP. But pretty much, I'm self-managing. And it's very important to people with chronic pain to understand what their condition is and how it affects them, to then get to a point that they can actually manage their day-to-day and take on help from a health professional when you feel it's necessary. Often you have to go to the health professional a little bit more often than you feel you need to, because other things come up and you put it down to your condition, your fibromyalgia. But it is important that you check in when something new happens and find out if it's worthwhile or if something has to change. But I'm fortunate in the fact that my care is quite stable, whereas others are very erratic, jumping from medication to medication. And if you had a group of 10 people and 3 drugs, you would probably find you could divide the room into a third, and one drug would work with 3 people, another drug would work with another 3 people, and another drug would work with another 3 people. Then you get that odd one out that none of them work. But it takes time. It takes years before you find something that might make a difference. Never mind get to a point that you perhaps recognize that your quality of life is quite a bit better than it was when you started.
Perfect. Thanks for sharing that, Des. And something that you spoke to about fibromyalgia really rang a bell with me. That it's not just chronic pain, and I think actually for lots of people with chronic pain, it's not just the pain in and of itself. It's all of the other aspects, you know, the psychological and social aspects, as well as, you know, other conditions as well. Wendy, as a specialist in treating patients with chronic pain, how does that ring with you? Do you think that's an important aspect of managing chronic pain?
I think that's absolutely right. I should say that my training is in rheumatology with pain management as well on top of that. So as a rheumatologist, I'm very familiar with treating thousands of patients with, well, treating is not really the word, on the NHS who have fibromyalgia. And you're absolutely right. When you speak to people in detail about it, it's the brain fog, or it's the fatigue, or it's this overwhelming, it's not just fatigue, it's overwhelming exhaustion that can be the most disabling part of this horrible condition.
I think just to add to that, it's also the stratification that you get within the community. You've got so many different subgroups of people. It's very hard to categorize people. So from one patient to another, a health professional will have, I always think they're the worst jigsaw to turn up on their doorstep, because first of all, they have to find out what it is that's wrong with us, but then we'll all present differently. And yeah, there's an antagonism sometimes that will come up as well, because you're going to this specialist to sort you, to fix you, as opposed to the expectations being that there is something that has to be managed and understood in yourself, as well as the health professional understanding where you are, and the fact that they're trying to make things better, not necessarily cure you. So it's a challenge.
Great, thanks both. And Katie, if I can come to you next, you know, Des talked a lot about you know, different medications that might or might not work for him, and obviously yourself as a pharmacist, you'll be, you know, very well aware of this. Can maybe talk a little bit about the role of yourself as a pharmacist within chronic pain management?
Yeah, I think, I mean, a lot of the complexities that have already been mentioned so far mean that sometimes I see people who've ended up on such a mixture, combination of many different medicines that have been started, not necessarily reviewed, or ending up on really high doses of things that aren't necessarily working, because for some people, when it's so complex, it's just so difficult to try and find something that does work. And as Des already mentioned, every patient is going to present differently. So when I see people at Sapphire, they've often ended up on combinations of higher doses of opioids, maybe other medications to try and manage the pain. And none of it's really effective for that patient by the time they've come to us. And if anything, the side effects of those medications can be causing more problem than the benefits they're getting. So particularly in terms of drowsiness, sedation that you tend to get with some of these medications, that's going to have such a big impact if fatigue and exhaustion is already an issue. So those are the kind of complexities that I see.
Great, thanks, Katie. Now, Jason, you've in addition to being a very well recognized researcher with respect to cannabis-based medicinal products, you've had a long successful career in looking at different aspects of chronic pain. How have you seen research in chronic pain sort of develop over the past 10 years? Are we getting closer to unraveling the silver bullet, or are we not quite there yet?
I think we're getting closer. I don't know if there's going to be a silver bullet. I take Des's point to heart, in the sense this is a very diverse population. There's not sort of one chronic pain phenotype out there. I think some of the things that are encouraging is that we are now starting to focus more on individualizing care. We're starting to look at what works for a person as opposed to an entire group. Certainly with respect to research and in particular guidelines, we're seeing better involvement of patient partners. So all of our guidelines right now involve patient partners who are formal panel members that actually vote on the final recommendations. We don't see this with all guidelines, but I think this is becoming something that is increasingly being expected. Certainly when we publish articles, for example, in the British Medical Journal, they now ask us to include a section specifically on how patients were involved in the research and what their contribution was. So I think as we start to learn more about the complexities, as we move away from a one-size-fits-all approach, and as we begin to do a better job of incorporating patient values and preferences, we're going to have evidence and recommendations that come out that are more accountable to patients, which are the ultimate stakeholder in any of these evidence syntheses.
Fantastic, thanks, Jason. I guess touching upon what you mentioned there about guidelines, we're now 1 year on from the UK guidance changing around chronic primary pain. So that's pain where there's no identifiable cause for that pain. We've seen a real stage shift in terms of the wording that's in there, guiding physicians against starting opioid medications, advising to consider when if they have already started on opioid medications, how to taper those down, and then also really limiting the other pharmaceutical options that are available there. In your experience, having written some guidelines to similar effect in Canada, maybe you can speak to how you kind of end up coming towards taking what the research we have globally and how you end up coming to those arguments.
Yeah, so there's a lot of good questions in what you just mentioned. So when looking at opioids, there was a highly politicized environment when we were doing our guidelines. The Centers for Disease Control had just come out with a guideline that essentially said they were unable to make any recommendation on use of opioids for chronic pain because they found no evidence from randomized controlled trials. Well, we found 96 trials. Why did they find none? They found none because they used as an eligibility criteria a minimum follow-up of 1 year. If you were to apply that as a criterion to evaluate evidence for any therapy in chronic pain, you would have virtually nothing to look at. So they put out essentially some guidance saying, you know, we're unable to make a formal recommendation, but they were quite pessimistic about use. And they made a very strong statement about bringing patients who are receiving over 90 milligrams morphine equivalent per day to doses lower than that. Well, we know that if people are on long-term opioid therapy, they are going to become physically dependent. That's not the same as addiction, but what it means is if you take people at high doses and you bring them down very quickly or cut them off, they go into withdrawal. The people go into withdrawal is quite terrible. We heard from our patient partners in our guideline that it was one of the key adverse events that they wanted to avoid. Many of them had had experience with that. Unfortunately, even in our neck of the woods, people took this recommendation very seriously, and clinicians were then being targeted for not prescribing greater than this amount. And with a proliferation of illicit fentanyl and other forms of street opioids available, we unfortunately saw a paradoxical response in the sense that these doses were being cut down very quickly, dramatically. Withdrawal was a very anticipated consequence, and a certain proportion of patients were then seeking out illicit supplies of opioids to replace their prescription drugs. And contrary to what the intention of the recommendation was, overdoses went up. So the authors of the guideline published a bit of a mea culpa in 2019 in the New England Journal of Medicine saying, don't do that. But that had been 3 years after Pandora was out of the box. And there's now been a number of influential studies that have documented that this blunt tapering, non-consensual is really disastrous and often leads to worse outcomes. So when we constructed our guideline, we did recognize that there was a dose response effect in terms of certain harms, but the evidence supporting it was only low in certainty. And we didn't know if tapering people off was likely to reduce their risks of those adverse events, including things like overdose, or not. And we knew there was a potential consequence to bringing people off their opioids. So we ended up making a weak recommendation to approach patients who were receiving high dose opioids and provide them with an opportunity to engage in a trial of tapering if they wished. And we put an associated remark with that recommendation where we advised if patients experience an unacceptable increase in pain or decrease in function as a result of a small reduction in dose, that it was quite reasonable to stop the tapering process, potentially even abandon it, to see how the individual patient was doing. We do see some interesting results from a great researcher in Stanford, Beth Darnell, who's looking at consensual, supported forms of tapering. And again, it's not a one size fits all. You sort of work with the individual to see where they might be able to come down. And that appears, at least for now, to be a successful approach. But indiscriminate, non-voluntary tapering really appears to be a problem. So again, I think what we unfortunately see in the world of pain is the pendulum tends to swing to one extreme than the other. First, it's opioids are being, very sort of, prescribed to a, very large extent, very high doses. And then all of a sudden it goes to the other extreme where no one should receive opioids. And the reality is the answer is probably somewhere in the middle. And that's a difficult thing to convey.
I think it might also be worth adding that the guidelines themselves that NICE have come up with are then interpreted by health professionals. Nothing unusual about that. But the interpretations that our community are finding are being made perhaps aren't what the guidelines for chronic primary pain are actually meant to do. Within those guidelines, it talks about the fact that if you are benefiting from a treatment, not just opioids, but gabapentin, pregabalin, if you're benefiting from a treatment, then the doctor should have a consultation with you, make you aware of the risks, talk about perhaps options, but not force you off of those medications. We've had so many people that have been forced off of opioids, forced off of pregabalin, and no alternatives made. We've also got reports of people that have had things, opioids, pregabalin stopped, just dead, no tapering, which everybody knows, yeah, that's not the right approach. So unintended consequences galore from that. But also, funnily, you were saying about the guidance and the eligibility criteria. Similarly, within the NICE chronic primary pain process, their eligibility criteria ruled out some evidence on tramadol because it didn't fit, evidence on gabapentin and pregabalin. I think it was mostly pregabalin because it didn't fit the criteria that they had at the start. Then when they made the decision, they said there was no good evidence because they didn't consider the evidence that was good. And this wasn't just ourselves that made this comment. If you look at I think it's a 1,100-page stakeholder feedback commentary on the guidance, repetitive comments from the likes of Cochrane, from ourselves, British Pain Society, NHS trusts. Why did you not consider the evidence to do with tramadol? It didn't meet our eligibility criteria. Repeated. So sometimes when you're creating the guidance, you're going to get an answer that perhaps you're looking for in the first place, a cynic would potentially say. But we've got people that are desperate to have help with their chronic pain, to find solutions. And they've got people that are like myself that are on an opioid that's now perhaps, again, tramadol is slightly different than opioids in a lot of people's consideration of them. But it's all opioids are bad at present. And there's others that are on pregabalin. We have an office administrator. That's what makes her life worth living and getting into the job that she's got, doing a part-time job with ourselves. So many stories like that, that the drug that they're taking, the medication, the treatment is what enables them to live, to then exercise. Yet the guidance talks about having exercise, but there's so many people that can't get to that point where they're able to increase the amounts of activity because they need something that helps them to relieve the pain, to then enable them to do something to help reduce medication, to then be more active. It's not a simple 1 + 1, and it's frustrating.
Yeah, thank you, Des. I think we can all agree with that. Wendy and Katie, I wonder if either of you could come in, sort of hearing about Jason's experience over in Canada, sort of adopted from the United States, and Des's sort of lived experience now, and from what he's heard from speaking to a number of people who live with chronic pain, how you interpret that guidance as clinicians, and have you seen any sort of adverse events of their implementation?
I've definitely seen a lot of patients who have just had their tramadol just stop, just like that. They go back for their repeat and the GP says, that's it, you can't have any more. We're not prescribing it anymore. And I suppose there would be attempt made to try and reduce it slowly, but it's made clear that that's their last prescription, and there's no arguing with that GP. So I've seen a lot of distressed people who've been in that situation. I haven't seen the overdose situation. Obviously, that's not my department, but many people like you, Des, do find that a little bit of tramadol or even a tiny bit of Oromorph is just what they need to help them. And so it seems very cruel that they're denied something that's useful. And similarly, I have started, not many people, but people that I have suggested to GPs that they might start on a small amount of gabapentin or tramadol. It's been resisted. So they're reluctant to continue prescriptions that have been started, even in secondary care.
Great, thank you, Wendy. Katie, did you have any points on that as well?
I was just going to say, so from like my experience with it is from the side of working in a medical cannabis clinic, and I do see patients who've come to us for that reason, because their medication's been stopped, not necessarily that the medication that they were on isn't effective. They may have been on an effective medication, but they're no longer able to access it. So yeah, I have seen it from that side too, same as what Wendy's saying. Yeah,
great, thanks, Katie. And I guess my next question is open to anyone really, is in the UK, our guideline making bodies have set out very strict, stringent criteria as to how they come to their decisions. And for lots of conditions, this makes sense. You know, there are cost effectiveness analysis that some conditions are very black and white, and the outcomes from treatment follow suit. Do you think fibromyalgia, chronic pain, really should have those criteria applied to them, or there should be nuance to how we create guidelines in the UK and internationally with respect to conditions such as chronic pain and fibromyalgia?
Well, we've still got a lot to figure out about what fibromyalgia is and how it affects people. We need flexibility, and the communications that Charity made round about the time that the CPP guidance came out was because chronic primary pain was a new definition in itself, which caused confusion to try and get it to that, to mention it in the draft guidance in the first place. But we need a bigger toolkit, not a smaller one. We need more options, not less, which was unfortunately the result of the guidance. We need flexibility. I suppose since we are mentioning about cannabis and there's a lot of anecdotal evidence from people that are perhaps getting illegal forms of it and finding that it's something that helps them. But then there's also people that are in a situation that they have it prescribed and it doesn't work for them. And then you get everybody that's trying CBD from, well, there's lots of people selling that with certain claims. So we need more evidence about anything that we're going to use for fibromyalgia, for chronic pain. We're finding out from brain scans that I think it was done with pregabalin. They could identify the people that pregabalin was not going to work on. They already had a suspicion from before they did the neuroimaging that there was a group that it just, and this is perhaps feeds into the efficacy. If we don't know who it works on before we even start it, then you're going to have a failure rate because it doesn't work in that subgroup. But they're getting to the point that potentially they can identify a cohort of people that it's not going to work on. And that would change efficacy ratings straight away. And it's okay, they were doing it with pregabalin, but it could apply to many other types of drugs as well. So we're going to find out a lot about chronic pain because we know not enough. But yeah, we need to be more flexible. And as long as it doesn't cause harm and people have informed choice, yeah, I think you've got to rely on the patient being able to try and help themselves as well.
Just to follow up on that, I think that we have to be careful about falling into the trap that just because a guideline comes from an organization with authority, that guideline is perfect.
Yeah.
I think we have to look at them carefully. I see, one question in the Q&A, for example, that talks about an individual who was on very high dose opioids, and they then were using cannabis as a way to reduce their reliance on opioids. They found that very successful. The UK NICE guideline on cannabis for chronic pain came out and said, opioid substitution does not occur when you give people access to medical cannabis. So what's going on there? We looked at the same 4 randomized controlled trials that they did. And sure enough, when people were provided access to medical cannabis, they did not reduce their use of opioids. But there was a major limitation of those studies. Every one of those trials directed patients to maintain their dose of opioids during the study. So they weren't designed to sort of look at that outcome. So the UK NICE group took an outcome that, yes, was reported in these trials, but it was completely nonsensical. So we looked at the same data and we said, yes, there's no effect, but of course there isn't if you tell patients not to reduce use of opioids. We then went to the observational studies, which are uncontrolled, but we did find a significant effect when people were provided access to medical cannabis, that in general, they were able to reduce their use of opioids by around 20 milligrams morphine equivalent per day. Now, those are observational studies, and the strength of evidence is lower because there's not a control group, because people know what's happening. But what it means is there's the potential. And now this question needs to be addressed in a more serious way with the right kind of randomized trials. But to simply take the recommendation by the UK NICE group on this issue, I believe would be very misguided. The other issue is they made a strong recommendation against use of medical cannabis outside of clinical trials for chronic pain. We made a weak recommendation in favor of offering patients a trial, giving them the option. How could we look at the same evidence and come up with very different recommendations? One of the main reasons was the UK NICE guideline looked at average effects only. And they found that on average, the effect is pretty modest. And it did not meet what we call the minimally important difference, which they defined as about a 1 centimeter improvement on a 10 centimeter scale. If you apply a minimally important difference to an average, you assume every single patient gets the exact same response to that treatment. And you assume there is no distribution. You've heard from multiple people on this panel that that is completely untrue. Sometimes the medication works for some and it doesn't work for the others. So we went one extra step and we modeled the proportion of patients that were likely to achieve the minimally important difference. Turns out it's 10%, 1 in 10. And then we went to patients after we did a systematic review of values and preferences, and we said, is this important? Would you be interested in a 10% chance of meaningful pain relief? And most of our patients said, if nothing else was working for me, I would be potentially interested in that. Tell me the downsides. Downsides are fairly modest. So that's why we ended up landing on a weak recommendation or a conditional recommendation in favor, because we know that the benefits are not going to work for most. They will work for some. And we thought it was reasonable to give patients the option, after providing them with details on benefits and harms, to make a decision consistent with their values and preferences. So again, 2 guidelines, same evidence they looked at, but very different approaches to interpreting.
Fantastic. Thanks, Jason. And I guess maybe sort of following on, because you spoke about your study there really nicely, is maybe some of the, in addition to the pain outcomes and the reduction in opioid use, maybe some of the other outcomes that you looked at within your systematic review and meta-analysis, and what you were able to find there.
Yeah, and as with any evidence synthesis, because we don't have all the evidence we like, there's limitations. So we weren't able to find trials looking at inhaled forms of cannabis. These were orals, predominantly orals, and a few topicals. But from what we did have, it looked as if there was a significant improvement on average in physical functioning, but it was small. You need to treat about 25 patients with cannabis to get one that notices an important improvement. With sleep quality, it was a little bit better. On average, it looked as if you had to treat about 17 patients to get one that would experience an important improvement in sleep. Now, the trials that we had to look at had fairly short follow-ups. Everything was about 5 months or less. Everything followed patients for at least 1 month. When we looked at other outcomes, emotional, social, and role functioning, we did not see improvement in those outcome domains. So what we saw was a modest improvement in pain and sleep quality, and a smaller improvement, still significant, in physical functioning. And we didn't see improvement in the other outcomes. Trading that off against harms, we saw a small but significant risk of several transient harms, such as limited sedation, perhaps a little bit of cognitive impairment, perhaps a little bit of dizziness. And again, these did not affect a large proportion of patients. It affected somewhere between 1 in 25 or 1 in 50, more so when compared to placebo. So again, you have evidence for modest benefits. You have evidence for the potential risk of modest harms. We don't have a lot of long-term data on more serious harms at this point. And we felt that allowed us, to make a weak recommendation. Could have been weak in favor, could have been weak against. In either case, weak recommendations mandate shared decision-making with patients. It is not a one-size-fits-all. Different patients will look at that information and make different decisions based on how they value those details.
Fantastic. Thanks, Jason. And to sort of add to that, I think at Sapphire, over 90% of our patients are enrolled in an observational series of data looking at how their pain interference levels and pain severity scores on the brief pain inventory change over time, and how their self-reported sleep quality and self-reported anxiety change over time. And And yes, the caveat is, like you mentioned with observational studies, the data quality is low compared to randomized controlled trials, but we've certainly seen that. And in a study that we've just submitted to a conference that isn't out yet, we've seen a statistically significant reduction in opioid medications during treatment. Whether it's quite a small amount, whether it's clinically significant, it's probably debatable. But yeah, we've definitely sort of seen similar findings with some of the observational studies that we've been doing in the UK at Sapphire. Katie and Wendy, how does that sort of chime with your clinical experience? You've seen hundreds, if not maybe more than that, patients with chronic pain. Are the things that the research is telling us, are patients also telling you that at clinical consultations?
Absolutely. I think even more so. I mean, I think there's a difficulty with some of the outcome measures that we're using because they don't necessarily equate to patients' experiences of this. So, for example, how can you measure the fact that someone has not been out the house for 4 years and then they can walk their dog, and that's what they wanted to do, and so they've achieved their goal. So from my perspective, that's what I am seeing as a cannabis prescriber. So it's the kind of things that I've never seen before, actually, with people who have chronic pain. So people's lives transformed in really unexpected ways.
Yeah, I would certainly agree with that. That's the kind of things that I'm seeing on a daily basis, rather than, I can speak more about what I'm seeing, with individual patients, sort of in real world experience. But what I see is those differences in someone's life that may not sound like a lot or may not be measurable, may not sound like a lot to somebody else, but for that one person, that's made such a big difference in their lives. Like I see patients at least weekly that have either gone back to work, which they never thought they would be able to do again. As you said, leaving the house, even, being more mobile around the house. And those differences are just astronomical for the individual person, but very difficult to quantify in any research. But yeah, I would totally agree with what you said. It's not something that I've seen in other clinical settings that I've worked in before. So it's quite a joy, really, to work with these patients.
Yeah, perfect. Thanks everyone. I think we've talked a little bit, well, quite a bit now about cannabis, but maybe people attending this webinar might not be familiar with, what is in cannabis, how might this be a potential benefit? Is it not just a plant? What is the potential medicinal value? How does it work on an individual basis? Katie, as our pharmacist, can I maybe point you to maybe talk about some of the main compounds within the plant that you would that you base your prescribing around?
Sure, I'll do my best. So our guidelines within Sapphire are usually based on a combination of CBD and THC, which is, the evidence we do have available is stronger for a combination of CBD and THC, and they both found in the plant, major cannabinoids in the plant, and they work in different ways. So having both together can complement each other. The THC is working sort of directly on the nervous system, on the endocannabinoid system, and can improve the way that you experience pain. And often if people do respond to it, they notice the effects quite quickly, is what I tend to find. And where CBD can often take a little bit longer to see the benefits. CBD is known to have anti-inflammatory effects, which can be very helpful for chronic pain. yeah, it's really based on a combination of both of those. That's how we structure our treatment anyway. And so, as we've already touched on, patients with chronic pain and with fibromyalgia are very much individuals. So it's about titrating the doses of those and getting the right balance for that person. And the other thing that we consider a lot with these patients is sleep. So sleep is so important for people with fibromyalgia, and THC we find can be particularly helpful for sleep, getting people back in a better sleep cycle. So that's kind of how we approach it at the clinic.
Amazing, thanks Katie, and sorry for putting you on the spot there a little bit there. Brilliant. So we have 15 minutes left. I want to encourage people to keep on sending in questions via the Q&A function. We'll definitely pick those up and put them to our panelists. So please get them in so I can continue to grill them over the last 15 minutes or so. Katie there's talked about sort of THC, tetrahydrocannabinol, and CBD cannabidiol. But there are a number of different compounds that are within the cannabis plant there. Jason, I don't know if you would be happy to speak to is there any evidence about the effectiveness of other cannabinoids or indeed terpenes or flavonoids within the cannabis plant, and if so, what is the strength of that evidence?
Yeah, so you're right. Cannabis is a plant. There's over 100 different active cannabinoids that are in there. The most widely studied, as Katie mentioned, are THC and CBD. But when you look at plant preparations, you're often taking on board a number of other active components, including the terpenes that you alluded to. And there are some patients that report benefit with this, what they call the entourage effect, where if you have THC and CBD on their own or purified, they might notice less of an effect than if there is sort of a more complete profile of cannabinoids from the plant. It's an area that we need to do more study on. It's an evidence where we need to understand more. One of the serious limitations of our evidence synthesis is we ended up combining all the forms of cannabinoids together. We made an effort to look to see if there were important differences based on higher levels of THC or higher levels of CBD, on whether there appeared to be important differences, whether it was a synthetic or a phytocannabinoid derived from the plant, or an endocannabinoid, which are cannabinoids that we make, right? We have very well developed endocannabinoid systems, which are important for a wide range of functions. The evidence is not detailed enough that it allowed us to do that. We are looking to see if there's an opportunity to perhaps get individual level patient data, which might give us a bit more of an opportunity to explore these things. But right now, I can just say we're not sure. We do have some individuals working within the research center at McMaster that are looking at certain types of cannabinoids as potentially quite potent antimicrobial agents to actually go after and attack pathogenic forms of bacteria. So there's potentially a wide range of use. This is a really new area. It's almost impossible to study illegal products, and cannabis has really only become legal, and still not legal in many parts of the world, but it's relatively a new opportunity. Even if you look at the US, cannabis is still illegal federally, right? It's only if you are in certain states that you might be able to access it for therapeutic purposes. And as soon as you go out of that state, it's an illegal substance. So we're slowly getting there. There's a lot more work to be done. There certainly is potential, but it's difficult now to make concrete statements.
Amazing. Thanks, Jason. We've had a number of questions come in now in terms of THC and CBD and these other compounds within the cannabis plant. Katie talked a little bit about them working together. Some people have asked about, do they work separately? Can you just be prescribed or study THC, CBD? Do we know those effects? If anyone's happy to speak to that.
I will. So some people do find benefit from either just taking CBD or THC. I'm not sure of the strength of the evidence of that. but because they've got quite different effects in the way that I explained, although backing up what Jason said, that what we do see is the whole plant extract does seem to be more beneficial for a lot of patients. However, taking the combination also has some other benefits, so not just about the efficacy of how well the drug will treat pain, but CBD is known to counteract the side effects of THC. So people tend to be able to tolerate THC better while taking some CBD. So you're getting the added benefits whilst being able to tolerate the side effects better. So that's an element to consider as well, and why the combination is often the best approach.
Great, thanks, Katie. Another very interesting question that's come through is given what we know about medical cannabis and cannabinoids, does anyone here ever think that they will be considered first-line treatments for chronic pain conditions? And I know what my answer would be, and my answer would be is that it's all evidence dependent, really. We can't really jump the gun on that one. It could be that it becomes a first-line treatment. It may be that we prescribe it less than we currently do, and that is all dependent on further research, as I think everyone here has highlighted in terms of really delineating both, as Des was mentioning really early on, is finding out more about the heterogeneous nature of fibromyalgia and chronic pain. It's not just one size fits all. It's learning more about those conditions and then learning more about how each medication fits into all those different subsets. And I think we're some way from that currently, but I mean, yes, in all possibility, yes, potentially, but certainly not for the moment. Fantastic. I
was going to say, just on that, even if we have it in, let's say, 10 years, I think would be optimistic, but any sort of a trial process for a medication, it's not just about whether it works, it's how it works with other things. It's one of the, whenever we have conversations within the community about cannabis, certainly somebody will shout out, make it legal, and then others will say, yeah, it works. But the process that a medication goes through in order to prove that it not only works within a certain patient population, it's also about how it actually interacts with these popular medications or this or that or whatever. So that's as much important to the process as it is about whether it works, which isn't necessarily a quick process, even if we get to the point of getting evidence that perhaps relaxes research grants more than it is at this moment in time.
Brilliant. Yeah, I 100% agree with you there, Des. I think we definitely need more of that right across the board. Some people have asked in terms of cost of medical cannabis and medical appointments. So in the UK, if that's where this person has asked the question from, medical cannabis is largely accessed through private medical clinics such as Sapphire Medical, and the cost of appointments is a flat fee at Sapphire. It's £50 per appointment. In terms of the individual average cost for using medical cannabis, this can really vary depending on what you're prescribed, and it really can be quite a broad range. But if you were to, if that's something that you're considering and you are deemed eligible by a clinician, they could work with you to find the best medication option for you in terms of looking at what is clinically the best option for you, but also something that is going to be more amenable to your budget. That's what I would say with regards to that. Yeah, you can hear of people on really high costs, over £1,000 a month, but then people at much lower costs, more like 2 cups of Costa coffee a day, something like that, around that. So it is really quite a wide range. So I would suggest if it's something you're considering, just check if you're eligible, have a consultation, and take things from there. Awesome. There's I'm aware of time, and we're sort of heading towards a close here. Does anyone here have any sort of parting thoughts or remarks that they would like to see, that they'd like to leave for our audience, or potentially a call to action maybe for future research and for guideline makers?
Maybe just one point, that unfortunately cannabis is sort of coming with a fair bit of historical baggage and stigma. And so you have a product that has traditionally been used for recreational purposes. It was really through anecdote and patient reports where there appeared to be some signal there that it might be a benefit for different conditions. But I think that when you're dealing with contentious areas such as cannabis, it adds an extra burden on doing the research. It can be harder to get research funds. It can be harder to publish research findings. But the story of Epidiolex, I think, is very encouraging in the sense that showing it can be done, right? It's now been shown in some very high quality randomized trials that for certain types of pediatric seizure disorders, giving these children quite high doses of purified CBD can help in a number of cases. So I think, with these examples that go out there, it's going to be easier to sort of get that next research grant to do something. I would encourage patients to try to get involved in research, to make sure that they have a voice at the table, that they're participating and making sure that outcomes that are collected are important. I'd encourage them to get involved in guidelines as well. And I'd encourage them to perhaps criticize guidelines that have completely excluded patients and patient perspective, because we know better than that now, and we shouldn't see that happening going forward.
Amazing. I think that is a really good note to end things on. So I just want to, first of all, thank all of our panelists for giving up their time this evening, or in Jason's case, this afternoon. It's been a really interesting discussion, and there's been some lively questions coming in through the Q&A. So it seems like lots of people have enjoyed it, and I hope they have too. So yeah, a massive thank you to you all for giving up your time, and obviously a massive thank you to all those who attended. We've put a short feedback form in the chat. If you'd be happy to fill that out for us, that would be absolutely fantastic. And this will shortly be available as a recording if you want to share it with friends, family, loved ones who you think it may be of interest to. So thank you all for your time, and yeah, have a lovely rest of your days.
Thank you.
Thanks so much.
Thanks.